Indonesia, in Malaysia, with India, and in fact in Africa, TB is still rampant, and we still have no magic bullet. Yes, we have anti-TB, but we should eradicate this like polio or like other infectious diseases. So if you look at inflammatory bowel disease, 19th century, UC and Crohn disease are very low in the part of the region or even in the West. But when we look at in developing countries in the mid-20th century, all this disease coming to us. So we are experiencing increasing inflammatory bowel disease that actually been experienced in our colleagues in the West, or we underdiagnose them still now, inflammatory bowel disease. So the subtype, I think all of us know, are the colitis of Crohn disease, but there are many aspects of overlapping syndrome between inflammatory bowel disease and irritable bowel syndrome, many subtypes of colitis, but very important, TB colitis is still everywhere in the large intestine, and they could present anywhere as part of the commonplace, which is at the ileocecal junction. If you look at the pathogenesis of IBD in terms of the genetic or exposure to environmental insult, high-fat emulsifier diet, gut microbiota, immune dysfunction that leading to chronic inflammation. But if you look at the literature before, it was thought mycobacterial tuberculosis was the initial etiological reason why the patient developed IBD, which is not true anymore. But in the past, it was really thought that TB, post-TB can possibly develop IBD. But I think it depends on how the immune system reacts, either Th1 Crohn disease or Th2 ulcerative colitis. Now, this is a typical life cycle of chronic disease. You get investigation, diagnosis, they keep coming to us, with all the relapsing remitting disease. And of course, the TB, when we eradicate, they are fine. And they do get some recurrence of the disease in certain high-risk individuals. So the endoscopy really to gain the tissue diagnosis for IBD. Yes, we have the upper GI tract, we have the lower GI tract. Don't forget, we also get mid-GI tract. All this necessary investigation that we need to get a sample to do the biopsy, especially difficult to get enteroscopy and lower GI. Mostly we can Google with colonoscopy or ileocolonoscopy and take biopsy and PCR, things like that. So basically the methods, not only a couple of things, but don't forget, we learn for the medical student, 80% of the diagnosis are relying from the history taking. So 20% actually rely on other tests. So the history taking we have, the good the diagnosis. So, but in reality, there are many things that we have to do in terms of histology and culture. We don't do, culture would take weeks to coming and all this fancy releasing assays, check for the IGRA test for TB, there are many other aspects. So go back to IBD, mostly they started for ulcerative colitis, they started distally from the rectum, they can migrate proximally, and Crohn disease mostly affected in the ileocecal junction, but anywhere from mouth to anus. But we all know the commonest spot for TB colitis is actually around the ileocecal region that confuse us with ileocecal Crohn's disease. The typical appearance of the ulcerative colitis is supposed to be normal like this, and it's supposed appearance of various degree of Crohn diseases. Normal will be like this, and this is a typical appearance of the ileocecal tuberculosis, where you get all the ulcers sometimes to the eyes of the surgeon, mimicking colorectal neoplasia, to the eyes of the non-IBD physician, look like a Behçet's. There's so many aspects of the diseases. So I think if you look at the progression of UC, we all know the majority are remission and in the first phase, and then develop after initial activity, and then chronic intermittent. So majority are chronic intermittent relapsing from the first episode of diseases in this UC. If you look at the Crohn disease, which is mimic more ileocecal tuberculosis, get right ileal fossa pain. Over the time, if you don't treat quickly, then you get a complication, stricturing, fistulating, then ultimately require surgical intervention. These are a big difference between colitis, ulcerative colitis, and Crohn disease in terms of presentation, but in practice, in real life, sometimes it can be either one presenting with the same thing. Again, localization, as I mentioned you early on, that the fistulating, very rare, we see in extremely rare in the ulcerative colitis, unless they got very deep ulcers. Sometimes we misdiagnose as ascaritis for Crohn disease. And granuloma also can present a very small percentage of UC. And also we all know the transmural is mostly for the Crohn disease. And again, granuloma, not that 100%, mostly we see microgranuloma in Crohn disease as opposed to large caseating granuloma in the case of tuberculosis. So these are the treatment goals for the IBD. We want to change the mucosa until here. Up to now, up to today, there is no cure for the inflammatory bowel disease. So I think all of us kind of know a lot of treatments, how we use simple 5-ASA for colitis, perianal abscess, antibiotics, and steroid, and then immunomodulators and biological therapy. I think a lot of Asian countries now have a version of anti-TNF alpha or anti-integrin alpha 4 beta 7, as well as targeting interleukin 12-23, ustekinumab also, and the oral therapy, JAKis or tafasitamab will be coming, I think, next year. So I think these are the personalized treatment for IBD. Still, we have no cure. If you look at the treatment for TB colitis, compared to years ago now, the Acrylic 4 tablet, which is combination of isoniazid, rifampicin, ethambutol, pyrazinamide, is handy for the patient. But of course, we have to be aware of all the side effects, changing the color of the urine and things like that. And to add on a pyridoxine, vitamin B6 for those on the isoniazid as a prevention for the peripheral neuropathy. So very important. So I'm going to go quite a couple of cases, Dr. Kaka, that we can learn all of us. For example, case A.
Please.
A 41-year-old presented with 2-month history of bloody diarrhea, weight loss, night sweat. You can see the marker here, ESR, not actually 100, as we see in the textbook, 38, thrombocytosis, a bit low albumin, raised inflammatory markers, stool culture negative, normal chest X-ray, mental test. These are the appearance of the ileocecal junction, like deep aphthous ulcers. We take the biopsy. Pathology say this is most likely Crohn disease. We give the intravenous steroid. You can imagine the patient was really deteriorated of clearly misdiagnosis of Crohn disease as opposed to a tuberculosis. So very important. Luckily, the patient survived, and then we review again a few things. Case B, a younger lady, 3 months again, more or less the same. Again, slightly elevated ESR, inflammatory marker also raised, normal mental test and chest X-ray. We thought this is histopathologically is a Crohn disease. We give oral steroid, luckily coming with very sick and increasing worsening of bloody diarrhea. And again, we misdiagnose again for the Crohn disease for the tuberculosis. So if we re-evaluate of the histopathology, you can see here the granuloma case A and case B very clearly that a tiny portion of the histopathology when we took that missed by the pathologists showing that this, even though microgranuloma, but it is actually, even despite negative mental test, or this I think is actually tuberculosis. And we do that again, sometimes patient has to pay themselves gamma raising assay, which is positive in the first case, but the microgranuloma, we re-evaluate, even though TB PCR is negative, then the both cases are well with the anti-TB for 9 months. So if I go to the third case again, a young guy, right iliac fossa pain, a weight loss, night sweat, again elevated of the inflammatory markers, then IGRA test is negative at this time, meant to negative. So we took the biopsy, again, on the eyes of these pathologists, chronic active ileitis. Then we thought that because this, we don't want to miss the TB, we treated with anti-TB medication, but absolutely no clinical improvement after 2 months. So what we're going to do next, we'll look at this DNA of the TB is actually detected. So we're wondering why anti-TB not responding. So we have to do that again. We have to write notes to the pathologist. Guys, is this TB colitis or ileocecal Crohn disease? We really have to know. Please recheck the status of the TB PCR. Is it positive or negative? You know, we have to get more information. So luckily, I mean, when we look back again, it's actually Crohn disease. And double check again, this PCR is not detected, and we start the steroid. So we waste 2 months of the patient quality of life, and we give the steroid, patient dramatically improve and start immunomodulators and doing very well, eventually with monotherapy of biological agent. Another case, last case, early last year. I'm sorry for my handwriting is very poor. Sometimes I cannot even read myself, Dr. Kaka. Pancolitis with bedwash ilitis. A young guy, a student, decided for Humira because do not want to come for the intravenous infliximab and TVO. Give usual thing, do chest X-ray and MAN2 test. And he's Malaysian, study engineering in Auckland, so he preferred adalimumab and is doing quite well. Guess what? He sent me the emails after the 3rd dose of the Humira. Listen, after the 3rd dose, I started to have a fever, and fever, I think I got worse. Send an email. I was reading the side effect of the Humira, the signs of infection, chills, muscle aches, blah, blah, blah. I have cough, fatigue, and I lost some weight. You know, when you got this email, bang, you worried about this. You just asked him to do like that, and then he just emailed the following day. My several chest X-ray, CT scan, I was active pulmonary tuberculosis. So this is a very healthy engineering student, 23 years old, no risk factors, got the BCG, and the eGRAS negative, you know. So, and then, you know, my communication late last year, and he's on observations, is really lessened. So post-TB treatment, restarted adalimumab, and then no problem arises. The last case, Dr. Kaka, this is a lawyer, a young lawyer, bright lawyer, 33-year-old lady, 3 months, right-sided abdominal pain, fatigue, weight loss 2 kilos, occasional loose stool, absolutely no respiratory symptom, no fever whatsoever. Look at the ESR 25. I know the CRP is elevated, chest X-ray is normal. You can see here beautiful at the ileocecal region of the colonoscopy. Look at my pathologists, very experienced pathologists. Look at this, chronic active colitis, ulceration, beautiful microgranuloma. This is absolutely Crohn disease. No question about that. So I routinely, as a first time, we have to do this DNA, which is TB is gone, IGRA is negative. Look at that, the MAN2 test, surprisingly, you know, 25 millimeter of the MAN2 test. Look at the quantiferon, which is positive. And again, we do all this TB complex and non-TB or non-detected on the specimen or any form. Again, treated with anti-TB for 3 months, great healing, and completed all 9 months together. And even though despite Crohn disease on the histopathology, but actually treated for Crohn. So lesson learned, ladies and gentlemen, we never stop learning, even though we are 80, 90 years old. Crosstalk with pathologists, microbiologists is worth more doing. Many blood imaging, thorough history is very important. Physical examination, must have high index of clinical suspicion for tuberculosis. Common things happen commonly. Not all inflammation for me as IBD physician must be regarded IBD is not. So there are many phases here. You can see on the top here, tuberculosis. There are many other phases like diverticular colitis. I think I've seen all of this, including a beautiful endometriosis that I missed in the sigmoid colon. Many of these can be appear, and now checkpoint inhibitors, colitis, a lot of people using immunotherapy. So it's exciting, and we have to be very vigilant on this. These are the typical appearance endoscopically. If you see, again, it may not be necessarily true. You really have to have a high index of clinical suspicion. So endoscopically, I think for non-infectious, there are features that we have to think about, what are they? And for the clinician perspective, when we supply the information to our pathologists, we really have to describe very well and really want to know what are they? Are the CMV colitis? Are they the TB? Other the graft versus host disease. I got a lot of in my album here. So pick and choose. So they can happen anywhere. If you look at the lead criteria distinguishing TB and Crohn disease, TB is thought to be transverse ulcers, Crohn's longitudinals. You can memorize this, but in reality, I'm sure Professor Ghoshal also agree. He see more TB than me. This is just in the theory, but you know, mostly common things happen commonly. Trust your gut feeling. If I look at Govin again, and Govin Makaria also put out the evaluation, the type of ulcers, TB circumferential as opposed to Crohn's, longitudinal, and any other endoscopy aspect, again, is not kind of a typical pathognomonic for anything in the large power. So any of you want to get a Nobel Prize winner for the next many years, please create biomarkers, molecular markers to distinguish ileocecal TB and ileocecal Crohn disease. I will guarantee 99% you will get Nobel Prize winner many years to come because no one has done that. So again, very important features, mucosa alteration in IBD and infectious. What are the things I'm looking for? I learned a lot from histopathologists. What are the features and the role of clinician pathologists from our perspective, the history, why we give this, what we have to write for them. Normal endoscopy in the terms of microscopic doesn't mean normal histology, where you take the tissues, how you cut that, exposure, minutes, medium, and the pathologist role also description to us very important. How the decision of the histopathology result gives us the trial or the pharmacotherapy of this patient. I mean, they really have to systematically approach assessing the tissue from the lumen up to the submucosa. Very important. I mean, I was religiously attended during my 20 years ago, I sit down with pathologists twice a week in the afternoon until the eyes got screened to look all this. But now I can appreciate the importance of this, how you describe the tubular crypts, epithelial and misplaced colonic mucosa, and what are the normal tissue like, and subepithelial collagen, what are the cellularity, which is more in the cecum for lymphoid cell, for example. These are very important. What are the normal looking, for example? And what are the abnormal chronicity, cryptolysis, any crypt, you know, Panacea metaplasia, sometimes very important for finding for this. And sometimes we have to go back, look at the Leonard-Jones criteria for Crohn disease. Of course, granuloma is the one main criteria, but in practice, they're not really having in practice, it's very difficult to diagnose this. So these are the perfect example for pathologists. They can put very clearly normal terminology of non-specific colitis. I'm sure Prof. Ari and Ghoshal and Dr. Kaka agree, non-specific colitis is not in the diary, meaning that the pathologists are not experienced enough, so committed to the diagnosis very, very well. So we all know complication of biological agent with a lot of giving pulmonary tuberculosis. A few studies, for example, the anti-TNF, which can, we know that reactivation of TB up to 25 times. We know that, look at the retrospective center over 10 years or so, this is old study. Again, biological agent anti-TNF, infliximab, higher incident for active tuberculosis. So maybe the use of different non-anti-TNF or anti-integrin that's supposed to be gut selective, maybe as an advantage to all of us here, preventing misdiagnosis, as Dr. Kaka said early on, from ileocecal Crohn disease as well as the tuberculosis. So these are the pre-checklist we have in the medical record as well. What we have to check before this, some cases, the patient have to pay, and they are standard. Some patient, if the routine chest X-ray, we're not happy, we actually ask the patient to go to CT thorax to make sure that there are no TB. Thank you. So latent TB as well, AOCC recommended prophylaxis for those who are taking this, and anti-TNF should be postponed, and reactivation is quite high. So the treatment of active TB diagnosed during the anti-TNF therapy must be stopped. We start anti-TB, and we can restart again anti-TNF after about 6 to 8 weeks or so. So take-home message is, There's an increasing trend of IBD in our region. We must understand how they're increasing. The burden of infectious colitis, tuberculosis, is still very high in our part of the region. Intervening early, have high clinical suspicious is very important. And tuberculosis is still around and around and around. We have to be very careful. Some cases, I think to be safe, therapeutic trial anti-TB is very important. Listen to your gut feeling. We are clinician, need to know the complication of particular biologic or immunomodulators and choose the treatment wisely and ask the colleagues, senior colleagues about this thing. So I think TB colitis is in the bush of IBD. It's like IBD is in the bush of IBS. So we really have to be very careful with that. So conclusion, Prof. Ari and gentlemen, history, endoscopy, imaging histology, very reliable for the diagnosis of both. Persistent communication between clinician and pathologist is very important. There is no place for one-man show in making any diagnosis in this era. These are the typical, our gastropathological, we have clinician one side, we got pathologists, we debate and debate and debate. We look at this, but eventually we have to win the argument, not raising the voice, speak with the facts, keep your cool, and then coming to the right diagnosis. With that, this is a new fresh from the oven. Rupa, myself, Shu, and Shashi, we just had a review 2 weeks ago in the gut and liver, how we're going to use biologics in the area tuberculosis endemic country. With that, Dr. Kaka, I thank you so much for your attention. These are the way that we look at specific disease. Sometimes we have to be very narrow, but we have to open-minded. Thank you so much, Dr. Kaka. Off to you.
Thank you so much, Prof. Raja. So you have exercised our doctors, and we have to be careful. Sometimes it can be tuberculosis. I bet that you must be very worried regarding your last patient. As we know, in this pandemic area, many lawyers hanging around our office, right?
Yes, so, yes.
I bet your communication with your last patient is very good, right? Because
yes.
because we have to very careful in giving this biologic agent. As we know that I also give so many patients with Crohn's for the step down therapy, and I prefer adalimumab because the patient no need to be hospitalized, right?
Yeah.
Okay. Thank you so much, Prof. Raja. Now we move to our second speaker and also our very beloved Dean, Professor Ari Fahrial Syam, who will talk about the intestinal tuberculosis that mimicking Crohn's disease. Prof. Ari, please.
Okay, thank you, Dr. Kaka. Also, I would like to say thank you on behalf of Faculty of Medicine in Indonesia to Professor Raja and also Professor Ghoshal. Because it's a local webinar, so please forgive me, I will give this lecture in Bahasa, but most of our slide in English. I think no problems with Professor Affendi, he can follow, but maybe problems with Professor Ghoshal, but all of my slide in Bahasa. Assalamualaikum warahmatullahi wabarakatuh. Terima kasih. Saya rasa di pagi ini memang di tengah kesibukan teman-teman semua, tapi kita kebetulan menghadirkan suatu topik yang menarik tadi sudah dimulai oleh Profesor Affendi, ya, bagaimana kita harus peduli terhadap kasus-kasus lower GI, pasien dengan klinis seperti tadi, diare kronik, kemudian juga kita endoskopi, ternyata sudah ada gambaran ulceratif, ya, kemudian juga ada sebagian pseudopolip, dan disitulah tempatnya apakah ini pasien dengan IBD, apakah ini pasien dengan TB. Seperti tadi sampaikan oleh Profesor Affendi bahwa kita mesti hati-hati di Asia Tenggara ini, ya mungkin di Asia Pasifik ini kasus meningkat, termasuk juga di kita. Ini Dr. Kaka sangat banyak pengalamannya menggunakan biologic agent untuk pasien-pasien dengan atau dengan colitis ulceratif. Nah, pada kesempatan ini saya ingin menambahkan beberapa kasus-kasus yang memang kita temui di praktek kita, dan juga terakhir nanti akan saya tunjukkan paper terbaru yang saya rasa bisa kita jadi patokan bagaimana kita memanage pasien-pasien dengan curigaan TB. Nah, ini saya rasa data terakhir bahwa kita memang punya PR untuk Indonesia. India ini jadi dari 8 negara ternyata 2/3 dari kasus itu ada di 8 negara ini. Jadi 2/3 kasus TB ini ada di 8 negara ini. India 26%, Indonesia 8,4%, kita nomor 2 di sini, ya China 8,4%, Filipina, Bangladesh. Dan yang menarik adalah, saya rasa ini juga menjadi penting buat kita semua, bahwa dalam periode Januari-Juni ini terjadi ada penurunan ya di awal, ya kemudian mungkin pasien ini sudah mulai kontrol lagi. Kita bisa lihat bahwa pasien-pasien sudah berani untuk datang ke rumah sakit, dan kita sudah mulai juga teman-teman yang endoskopi ini sudah melakukan lagi endoskopi, dan kasus-kasus ini mulai ketemu lagi dengan kita gitu ya. Nah, ini India lebih cepat dia, jadi mungkin pasien datang udah mulai cepat datang. Kita agak lambat di sini, Juni, nanti tentu angkanya akan kita lihat terus, apakah memang terjadi peningkatan kembali dan mungkin juga di sini. Jadi memang di satu sisi pentingnya rumah sakit itu untuk melakukan screening yang tepat untuk pasien-pasien COVID sehingga ada kenyamanan untuk pasien-pasien non-COVID untuk berobat. Karena kalau tidak kita akan miss. Ini turun ini bukan karena kita berhasil, tapi turun ini karena memang kasus itu tidak datang kepada kita gitu. Ini hal yang jadi harus menjadi perhatian kita. Ya. Nah, ya saya ingin menyebutkan tadi bahwa memang ekstrapulmonary tuberculosis itu sesuatu hal yang harus menjadi perhatian kita. Bisa saja pasien itu datang dengan, oke ini kita bicara soal GI, bisa juga pasien datang dengan limfadenopati. Ya, limfadenopati. Nah, ini tadi nih kita dalam masa 6 bulan itu tadi hitungannya 6 bulan sudah ada pasien kembali lagi, 7 bulan 8 bulan kalau dia menunda datang untuk ke rumah sakit ini makin kelihatan gejala klinisnya ya. Ini yang mesti menjadi perhatian kita. Jadi dan yang salah satu yang utama daripada extrapulmonary tuberculosis adalah intestinal tuberculosis. Ya, dia bisa menyerang di usus, peritoneum. Ya, saya sering menemukan beberapa kasus pasien ya akhirnya saya melakukan empiric treatment, ASI tes yang tidak jelas, kita aspirasi juga tidak jelas, akhirnya kita obatin dengan dengan obat anti tuberkulosis, ternyata responnya cukup baik. Jadi beberapa kasus itu datang dengan kondisi seperti itu, karena memang bisa saja dia menyerang di usus atau di peritoneum. Nah, disebutkan, nah bisa juga, saya selalu tanya biasanya bagaimana dengan menstruasinya biasanya. Dia ada gangguan menstruasi. Nah, ini kita bisa bilang bahwa juga mungkin organ-organ organ-organ genitalia internalnya juga sudah terganggu pada pasien tersebut. Dan bisa juga melalui darah begitu ya. Bagaimana tadi kita bisa menjelaskan pasien dengan tuberkulosis, kemudian juga kita bisa melihat komplikasinya ke usus begitu. Nah, ini tadi. Ya, jadi bisa tadi mungkin fototoraksnya sudah bersih. Ya, atau tadi memang pada saat bersamaan ini memang kita dapatkan fototoraks seperti ini, saya rasa khas sekali ya, pasien dengan fibroza infiltrat di kedua apex, dia bisa kena ke liver, ya TBC hati, kemudian tadi di daerah alopi tadi ya, kemudian di daerah usus di sini. Jadi dan juga bisa kelimpa juga bisa terjadi. Jadi sekali lagi bahwa ekstrapulmonary itu bisa terjadi di beberapa organ dalam ya. Dan kalau kita lihat perkembangannya tadi, awalnya bisa saja gambarannya seperti ulceratif ya, klinis pasien dengan kronik diare, kemudian hipertropik, pasien sudah mulai nyeri, apalagi sudah terjadi obstruksi, pasien juga nyerinya bertambah dominan, ya kadang-kadang bisa dia bilang kadang-kadang susah BAB, kadang-kadang diare, ya. Dan apabila memang sudah berbagai macam lesi yang ditemukan, maka muncul gejalanya sudah bermacam-macam gitu, bervariasi nyeri, ya apalagi tadi cardinal sign dari tuberkulosis mestinya datang, dapat kita lihat berat badan turun, kemudian juga pada pasien itu juga misalnya banyak keringat malam ya, night sweat, itu juga bisa kita temukan. Nah, ini satu mulai kasus yang kita publish di Indonesian Journal Gastroenterology and Pathology, ya pasien sekali lagi usia muda, 22 tahun seperti kasus yang disampaikan oleh Profesor Affendi tadi, beberapa usia muda, nyeri perut yang dominan pada pasien ini, mual dan muntah, ya, dan juga nafsu makannya menurun, berat badan turun. Ya, ini klinis kalau sekilas tadi kita bilang sama seperti juga IBD juga sekilas seperti ini, tapi yang menonjol memang dia ada fever dan night sweat. Nah, ya, kemudian tentu pasien ini, nah bagaimana sih sebenarnya pasien-pasien dengan TB? Ternyata memang demam itu hanya 4-70%. Nyeri perut yang dominan. Ya, jadi perut bisa bentuknya kolik tadi kalau memang sudah terjadi stenosis pada pasien tersebut ya. Kemudian juga kalau sudah lymph node-nya terlibat. Berat badan turun ini hampir 90%, 40% berat badan turun. Nafsu makannya juga menurun ya. Nah, ini saya bilang tadi nih. Jadi seperti colon cancer pasien ini. Jadi kadang-kadang dia constipation, kadang-kadang dia diarrhea ya. Jadi malaise ke pasiennya dan juga diare bahkan tadi disebutkan hanya 11 sampai 20% untuk intestinal tuberculosis ini ya. Jadi bisa saja pasien bilang BAB berdarah seperti ini datang kepada kita dan balik lagi kepada pasien ini BMI-nya memang rendah sekali ya pada pasien 17 ya dan jelas tadi pucat pasien kemudian normal dan tadi nih ya tidak ada tanda-tanda nih kebetulan ya. Jadi ada nyeri tekan di daerah kiri bawah dan terus terang saja beberapa kasus pasien-pasien dengan nyeri kanan bawah diduga apendisitis akut, kemudian sempat dioperasi, diangkat dan hasil dari biopsinya ternyata ditemukan adanya granulomatosa seperti yang disebutkan oleh Profesor Affendi tadi. Jadi tegak diagnosis TB setelah dilakukan pemeriksaan dari appendix bisa terjadi seperti itu gitu ya karena tadi pain tadi. Oleh karena itulah maka ketika pasien ini memang nyeri perut kanan bawah kita mesti pastikan ini acute atau kronik. Dan kita lihat lagi cardinal sign-nya tadi, berat badannya turun atau enggak. Karena pasien ada satu pasien saya, padahal berat badannya turun, tapi tetap waktu itu dokter bedah tetap menganggap ini suatu acute appendicitis sehingga dilakukan operasi pada pasien ini. Padahal tadi sudah ditemukan cardinal sign pada pasien ini yang mengarah ke suatu chronic disease, gitu ya. Nah, kembali lagi HB-nya 10,1 tadi. Nah, ini jelas ini peningkatan dari laju darah ya 28. Nah, ini yang menarik ya, terjadi trombositosis karena tadi perdarahan yang tersembunyi pada pasien ini, albumin sudah mulai menurun pada pasien ini ya karena tadi chronic disease, fungsi hati masih bagus ya. Alhamdulillah berarti kemungkinan keterlibatan liver tidak ada pada pasien ini. Dan tadi yang saya bilang, kasus ini kebetulan chest X-ray-nya normal ya. Kemudian dicoba juga diperiksa untuk darahnya juga negatif ya. Nah, kemudian pas feses kan rutin kalau pasien diare kita lakukan misalnya feses ini mengarah kandida. Jadi tentu kita berpikir ini pasiennya dengan kandidiasis gitu ya. Oke, ditreatment dulu dengan kandidia. Baru akhirnya tidak sembuh baru kita teropong. Kalau saya sih lebih balik lagi begini, kalau pasien ini kronik diarrhea, indikasi apalagi tadi umur masih muda dengan berat badan turun, saya lebih cenderung kolonoskopi pilihan pertama daripada kita ngobatin dulu tadi dengan kandidanya. Jadi lebih baik kita kolonoskopi dulu. Jadi gambaran ini yang muncul pada pasien ini. Jadi pseudopolip ya, kemudian pseudopolip seperti ini ya, kemudian juga ada ulceration pada pasien ini udah mulai kelihatan di sini, hyperemic ya dan memang dominan ini di ileocecal region ya. Dan hasil daripada PA-nya tadi ada atypical tubercle, epithelial cell, dan severe dysplasia. Jadi tadi Prof. Affendi memang membutuhkan kerjasama antara kita sebagai seorang clinician dengan patologisnya. Mesti tegak misalnya berani bilang bahwa ini memang sesuai dengan IBD, Crohn disease, atau dengan TB. Walaupun hal itu kadang-kadang juga sulit untuk dokter patologis untuk menyampaikan hal tersebut. Begitu ya. Jadi tadi ya idealnya memang kita kolonoskopi, kemudian kita culture ya, kemudian juga tadi sesuai dengan tadi sampaikan juga mengenai PCR test pada pasien ini. Nah, tadi saya sebutkan bahwa memang patogenesisnya ini belum kita mengerti sebenarnya bagaimana sih tadi kan kemungkinannya apakah ini secara dari darah, apakah ini memang infiltrasi atau memang itu sudah ada di situ misalnya ya. Dan pada usia muda tadi 2/3 dari kasus yang ditemukan ini usianya muda ya dan tidak ada perbedaan antara laki dengan perempuan ya. Dan kalau kita lihat di sini ya pada pasien ini kemungkinan yang tadi ya, jadi bisa melalui darah ya, bisa melalui organ sekitar pada pasien ini. Ya, di sini umumnya tadi yang saya bilang tadi bahwa the most frequent intestinal location in ileocecal area. Ya, jadi ini yang karena tadi ya di berdekatan dengan payers patch ya pada lokasi ini begitu. Nah, ini tadi saya bilang kalau kita langsung nyeri tekan, nyeri lepas ini sekarang appendix ya kita mesti lihat dulu chronic disease nggak ini pasien. Ya, lebih baik kalau memang kita masih mencurigai ke arah TB ya tentu kita screening dulu, coba foto torak walaupun tadi bisa normal, IGRA tadi bisa dia memang kita harapkan tentu maunya sih naik begitu ya, tapi bisa juga itu tidak ketemu sehingga memang bisa saja secara kebetulan tadi ternyata diagnosis ditegakkan dari hasil histopatologi dari hasil appendix ini ya. Jadi ya sekali lagi bahwa tidak spesifik ya, memang susah untuk kita mau coba awal tadi ya. Dan tadi disebutkan bahwa diferensial diagnosisnya dengan beberapa keadaan ya, baik itu Crohn disease, ulcerative colitis ataupun malignancy ya.
5 menit Prof. Ari.
Ya, dan sekali lagi bahwa negatif tuberculosis ini tidak bisa rule out dari diagnosis ya. Kemudian sekali lagi juga cek X-ray juga kita bisa tidak temukan pada pasien ini. Ya. Dan jelas awal kita mesti kolonoskopi. Terus terang saja sebagian dari teman-teman kita relaktan untuk mengerjakan kolonoskopi ini dengan berbagai alasan, tapi tetap standar kita juga mesti screening. Nanti mungkin kita tahu ya informasi dari teman-teman di India atau di Malaysia bahwa kita saat ini menstandarkan swab dan foto torak pada pasien sebelum dilakukan kolonoskopi gitu ya. Ini jelas kalau ketemu seperti begini, ini kebetulan yang Crohn disease tadi untuk diferensial diagnosisnya, ini kebetulan yang Crohn's disease ya tadi. Nah ini ada satu kasus lagi jadi bahwa pada pasien-pasien yang datang dengan acute abdomen ya, kemudian juga ternyata terjadi ini bisa suspek Crohn disease ya. Bisa saja dibuka dan dari hasil ini ketahuan bahwa itu ternyata tuberkulosis ya. Oke, jadi dan ternyata pasien ini memburuk setelah dioperasi dan ternyata dari hasil ini ditemukan miliary TB ya, kemudian juga ditemukan tuberkulosis, ditemukan granulomatosa pada liver, spleen dan juga ini transmurat tuberkulosis ya. Ini contoh yang diduga dari Crohn ternyata memang sudah dapat TB pada pasien ini. Nah, ini satu kasus lagi secara singkat tadi saya sampaikan. Kalau ini kebetulan kasusnya jelas ditemukan infiltrat, fibro infiltrat, dan ya ini juga ada acid test ya, sekali lagi tadi lymph node, pembengkakan dari lymph node pada pasien ini, kemudian dari hasil kolonoskopi memang lebih diferensial dan colitis infected, ulceration, dan ternyata hasil PA ini penting sekali, data ini full blown pasien ini kita temukan adanya tubercle ya, jadi dan ini confirm bahwa kita menghadapi suatu ya. Nah, ini kebetulan pada pasien ini gambarannya ya pada saat di awal dan ini obat yang kita berikan. Baiklah untuk teman-teman semua, jadi ini ada satu yang disampaikan oleh teman-teman dari India, publish di World Journal Gastroenterology. Kalau kita tadi mencurigai pasien ini, ya tentu kita lihat dulu pada pasien ini, kalau kita memang agak ragu, misalnya tadi dari hasil pemeriksaannya ada, kita bisa coba dengan antituberkulosis, kita lihat apakah ini membaik, kalau membaik tentu kita bilang TB misalnya, ya kemudian kalau ini memburuk, ya tentu kita ulang lagi, ya ini apakah memang ini suatu atau ini. Dan satu hal lagi tadi menarik disampaikan oleh Prof. Raja bahwa bisa saja terjadi TB usus on Crohn disease. Ya, jadi hal-hal yang ini harus kita perhatikan. Jangan-jangan kalau memang ini sudah diobatin, kemudian juga masih ada gejala yang muncul dan ada gambaran aktif, jangan-jangan ini memang double tadi ya, jadi suatu Crohn's disease. Tapi kalau memang murni bersih, hilang sama sekali, berat badan bagus, kita bisa bilang ini murni intestinal tuberculosis. Baiklah, Dr. Kaka dan teman-teman sekalian, ini hal yang saya ingin sampaikan, mempertegas yang disampaikan oleh Profesor Raja, kasus-kasus yang ada di kita, di FKUI RSCM, dan kebetulan kita publish di jurnal kita. Ya. Jadi sekali lagi, bahwa di awal memang sulit untuk melakukan untuk diagnosis awal pada pasien-pasien dengan tuberkulosis, karena gambaran kliniknya yang bermacam-macam, dan tetap kita harus melakukan differential diagnosis dengan Crohn's disease, ya, IBD, malignancy, dan negatif tuberkulosis tidak bisa merule out diagnosis untuk arah TB, dan begitu pun juga tissue culture yang tidak selalu positif. Chest X-ray untuk screening awal, pada kasus yang pertama negatif, pada kasus yang kedua kita tunjukkan ada gambar yang positif. Jadi sekali lagi tetap ini screening kita lakukan ya pada pasien-pasien yang mencurigai tadi, walaupun mencurigai Crohn, untuk kita lakukan screening. Toh juga pada pasien yang kita akan berikan biologic agent, saya rasa kalau kita sudah screening bahwa ini free TB, maka tidak akan ada masalah kalau kebetulan pasien itu mengalami komplikasi TB paru atau mungkin juga TB usus setelah kita obatin sebagai Crohn disease. Lebih dan kurang saya mohon maaf. Assalamualaikum warahmatullahi wabarakatuh. Silakan Dokter Kaka.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Professor Ari. Sometimes, as an Indonesian, I envy to Malaysia and India as Commonwealth country because they have English for their first language, Prof. Ari. So their doctors are very, very good in English, so they can understand. So as Indonesia, we are colonized by Dutch, but we cannot speak Dutch. Yeah. As we know that, like Prof. Ari said, that intestinal tuberculosis is a very troublesome condition and really can be mimicking so many conditions like Crohn's disease. But now we have also another troublesome issue that will be taught by our third and last speaker, Professor Uday Ghoshal from Lucknow, India. He's medical teacher with an experience of teaching postgraduate level for more than 29 years. And he has more than 252 publications. Wow, congratulations. Amazing. Without further ado, Professor Uday Ghoshal will talk about an update on irritable bowel syndrome. This is very important for us because irritable bowel syndrome is very troublesome and can lowering the quality of life for patient if it's not treated properly. Prof. Uday, please.
Thank you. Thank you, Dr. Ari, Dr. Kaka, and Dr. Raja. It is a pleasure for me to speak from India, from my home, in a meeting in Indonesia. So I bring greetings from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. I'll be talking on an update on irritable bowel syndrome. I'll primarily focus on diagnosis, some aspects of pathophysiology, and treatment. Now, if you say how common is functional gastrointestinal disorder in general and IBS in particular in the world, this is the global epidemiology study of Rome Foundation, in which Malaysia and Indonesia is also a part, in which 33 countries were surveyed in 6 continents, and more than 73,000 people were surveyed, either by internet or by household, and we found functional gastrointestinal disorders are common, including IBS, and the frequency was found to be higher in internet survey countries than household survey countries. Now, what is IBS? Rome 4 criteria said that the patient should have recurrent abdominal pain at least 1 day per week in last 3 months associated with 2 or more of the followings related to defecation, associated with a change in frequency of the stool or the form of the stool, and it must have been present for more than 6 months. Now, you don't make this diagnosis easily if patients have alarm symptom, because alarm symptom may indicate that the patient may be having an organic disease. So you investigate adequately before you make a diagnosis of IBS in patient with alarm symptom. What are these alarm symptoms? Age greater than 45 years, anemia, blood in the stool, unintended weight loss, nocturnal symptom, fever, abdominal mass, and family history of colorectal cancer. Now we are talking about Rome 4 criteria today. Somebody will ask, is Rome 4 criteria a panacea? Is it casted in the stone? We have realized it is not. As time is passing, we are realizing more and more that Rome 4 criteria has made diagnosis of IBS quite restrictive. Here is a study from UK, another study from India, and a third study from China. What does it show? It shows that actually if you make diagnosis of IBS by Rome 3 criteria, you make diagnosis more often than if you make diagnosis by Rome 4 criteria. Why is it so? It is because Rome 4 had made pain to be essential. And we all know that in the Asia in general, and even also in India in particular, and also pain not present universally in IBS patients. Actually, a higher symptom frequency with this virus more difficult. I would say Rome 4 criteria is less sensitive than Rome 3 criteria for IBS in general and in Asia and India in particular. Now, when you make a diagnosis of IBS, you really treat them unless you type them. Because if he has IBS-D or predominant IBS, he requires a different treatment than somebody who has IBS-C or constipation predominant IBS.
Halo Mbak Indah, saya rasa
Yes, I think, yeah. Shall we continue?
Prof. Uday should, okay, please.
There was a technical glitch. I'll continue. I'll share the screen first. Okay. So you can't treat patient with IBS unless you subtype them. Because if suppose somebody has IBS diarrhea predominant, he requires different treatment than somebody who has constipation predominant IBS. How do you subtype the disease? You subtype based on symptoms again, and particularly you look at Bristol stool form. According to the Rome guideline, if predominant stool is type 1 or type 2, this is constipation predominant IBS. On the other hand, if stool type predominantly is type 6 or type 7, this is diarrhea predominant IBS. But we realize based on the studies from Korea, India, and other countries of Asia, that in Asia, even type 3 stool should be considered as constipation stool and not like European or American guideline where type 3 stool is considered normal. Now, after the diagnosis of IBS is made, current Rome 4 guidelines suggest that you have to actually look at multidimensional clinical profile. What is multidimensional clinical profile? Multidimensional clinical profile looks at other issues in a given patient. For example, the patient may have mild disease, moderate disease, or severe disease. Obviously, severe disease has to be treated more aggressively than mild disease. Patient can have several psychological issues which are important confounder in the treatment, and patient may have physiological dysfunction which also require physician's attention. What are these physiological dysfunction? For IBS constipation, you have to look for fecal evacuation disorder or slow colon transit. That means patient with slow colon transit may have constipation and they can have symptoms similar to a constipation predominant IBS unless you improve their transit, they may not improve. Similarly, patient with IBS diarrhea may have lactose or fructose malabsorption, bile acid malabsorption, non-celiac wheat sensitivity, small intestinal bacterial overgrowth, and post-infectious nature of the disease. Now, how common is the post-infection IBS? What is post-infection IBS? Post-infection IBS is following an acute gastroenteritis episode. A patient can continue to have bowel dysfunction, fulfilling criteria for post-infection IBS, and they usually have, after acute gastroenteritis, about 10% patient can continue to have post-infection IBS. What is new in relation to post-infection IBS in the world today? This is one of our studies that we did in Bangladesh. And interestingly, this study, which we published about 2 years ago, we found that cholera can cause post-infection IBS. Cholera is supposed to be a non-invasive pathogen, but now we are realizing it may be micro-invasive and can cause long-term dysfunction of the gut. And also we found 9% patient with post-infection IBS who fulfilled criteria for IBS actually had malabsorption, and they probably need treatment of post-infection IBS. How common is small intestinal bacterial overgrowth in irritables? Here, 3 meta-analyses came out, one from Italy, one from India, and one from Australia. And this meta-analysis showed that 10 to 20% patients with IBS, particularly those with diarrhea predominant IBS, may have small intestinal bacterial overgrowth. Another issue that you have to realize that IBS is a state where there is an abnormality of the serotonergic neurotransmission. Serotonin is an important neurotransmitter of gut, and when you have excess serotonin in the gut, it causes diarrhea. When you have serotonin reduction in the gut, it has constipation. And why I'm talking about it, it is because this pathophysiology will translate into treatment. Let us come to the treatment then. Now, depending upon whether you are dealing with constipation predominant IBS or diarrhea predominant IBS, treatment are different because they have different putative pathophysiology. For example, diarrhea predominant IBS, constipation predominant IBS patient may have slow motility. So how do you treat slow motility? You give different prokinetic. For example, etopride, levosulpiride, mosapride, procalopride, domperidone, metoclopramide, cisapride, tegaserod. Some of these drugs have already been withdrawn. And some of these serotonergic agents, some of these pro-motility agents are serotonin agonist. For example, procalopride is serotonin agonist, cisapride is serotonin agonist, mosapride is serotonin agonist. And I told you, actually, serotonin deficiency causes constipation. We all know that osmotic load improves patient with constipation. Therefore, you treat with osmotic agent. Fecal evacuation disorder patient would require biofeedback. Look at diarrhea predominant IBS. We all know food fermentation product are osmotic agent and cause diarrhea. Therefore, elimination of those food will be useful in treatment of IBSD. We all know increased bile acid can cause diarrhea. Therefore, you can treat this patient with cholestyramine, cholestyramine, cholecephalam, and so on. We know gut microbiota and small intestinal bacterial overgrowth can cause diarrhea. Treat them with rifaximin and probiotic. We know fast motility can cause diarrhea. Therefore, treat with anti-motility agents such as loperamide, diphenoxylate, anticholinergic, including tricyclic, acimardolin, iloxadolin. We know high serotonin can cause diarrhea. Therefore, you treat with anti-serotonergic such as alocetrone, cilacetrone, ramocetrone, and ondansetron. Inflammation and mast cell can cause diarrhea. Mesalamine and mast cell stabilizer, though these are in experimental stage, they are not found clinically useful. Now, this is a study of ramocetrone in male patient with IBSD. It is a serotonergic antagonist, and it was found useful. This is the spiller on ondansetron in IBS, And again, it is a serotonergic antagonist. It is a serotonergic antagonist, and it is useful. Now, how about treating IBS patient with antibiotic? This is the famous target study in which more than 1,200 patients of non-constipation IBS were treated with rifaximin and placebo. And the Mark Pimentel found that 40% was the improvement among patients who were treated with rifaximin compared to 30% with placebo. So incremental response was only 10%, but it was statistically significant. Why is the incremental response so low? It is because these authors treated the patient in an unselected manner. Unselected means they did not look at whether the fellow had bacterial overgrowth or he did not have bacterial overgrowth. And now I tell you that obviously if you test for bacterial overgrowth and treat them, response rate would be much higher. And this is the first study in the world on this issue that we performed, where we randomized patient with bacterial overgrowth and IBS into an antibiotic, norfloxacin or placebo. Those who did not have bacterial overgrowth, we randomized similarly, and the response rate was 87%. And now this concept has been substantiated by a study from China and another recent study in US published in American Journal of Gastroenterology. Now, if you treat somebody with antibiotic, how long does the response last? These are the two studies, the upper panel, our study, and the lower panel is Mark Pimentel's study, which showed that if you treat them even successfully, the response lasts only 8 to 12 weeks. Can you retreat them again with rifaximin? Yes, you can. And this is the Target 3 study published by Anthony Limbo, which found that actually if you treat them again and again with rifaximin up to 4 times, they respond. Now, does probiotic work in treatment of irritable bowel syndrome? Yes, the results are quite mixed. Universally, it doesn't work, but most studies showed bloating is one symptom in which probiotic lead to improvement. Fermentable oligo, monosaccharide, and polyols are the dietary ingredients which increases osmotic load in IBS patient, and therefore they exaggerate symptoms such as diarrhea, pain, and bloating and gas. And now there are quite a few studies in the world that showed, these are randomized control trial that showed that if you restrict FODMAP content in the diet of patient with IBS, it works. Obviously, we need more data on this in Asia because food habits among Asian in general and Indian in particular is quite different. Indian diet is typically very high in FODMAP content. Now, how do you treat constipation predominant IBS? You give a lot of osmotic agent. You can treat with chloride channel activators such as lubiprostone. You can treat with guanylate cyclase C agonists such as linaclotide. You can treat with serotonin agonist, that is procalciprate. Abdominal pain, initially you try smooth muscle relaxation, peppermint oil. If it doesn't work, then you can move to visceral neuromodulator, which are typically called psychotropic agent, but in Rome we have changed the terminology now. These are called visceral neuromodulator, and the important one are tricyclic and SSRI. Can you treat constipation predominant IBS with antibiotic? Because Target study actually excluded patient of constipation predominant IBS in the rifaximin trial. Now, can you treat constipation predominant IBS with rifaximin? Here are 3 studies in the world, 1 retrospective and 2 randomized controlled trial. Initial 2 studies are from US and the randomized controlled trial 1 is from India, published recently. What happens is constipation predominant IBS may have slow gut motility or slow colon transit. Now, some patient with slow colon transit is slow because of excess methane gas in their gut because of presence of methanogenic flora. Methane is a nerve gas. It slows the gut transit by inhibiting neurotransmission, reducing the serotonergic expression. Now, what happened is if you give rifaximin, you can reduce the amount of methane. and therefore you can improve constipation. So in constipation, predominant IBS, Rifaximin, like unselected, only those with slow transit who have excess methane, it is worth trying. Now, how about TCA and SSRI? There are several meta-analyses, and this is one of these meta-analyses which show some of the SSRI realist use. Also, even in absence of psychological abnormalities or psychiatric diagnosis. What does it mean? They work at visceral level, they work in the gut level by influencing enteric neurotransmission. Therefore, let me tell you, summarize, we do a diagnosis by IBS, either by Rome or Manning criteria. We always do an MDCP evaluation, looking for severity, looking for physiological dysfunction, looking for psychological issues, looking for dietary issues. Then if it is IBS-C with constipation, or IBS-C, that means constipation, predominant IBS with bloating, remember fiber, because fiber increases bloating. You give something else. For example, you can give milk of magnesia, you can give polyethylene glycol, they cause less bloating. Now, if there is no response, we do a colon transit time using radiopaque marker in our setup. Test for fecal evacuation disorders such as rectal manometry, balloon expulsion test in our setup. And if there is slow transit, we give procalciprate. If there is fecal evacuation disorder, we give biofeedback. If both are present, we treat by a combined manner. If pain predominant IBS, we give anticholinergic, otilonium bromide, pinavarium, mevaverin. These are smooth muscle relaxation. If there is no response, we add psychotropic agent. This is now classified as visceral neuromodulator by Rome Foundation. Now, IBS-D, be careful. You may be dealing with something else. For example, you may be dealing with small intestinal bacterial overgrowth. You may be dealing with celiac disease, microscopic colitis, collagenous colitis, lactose and fructose malabsorption, parasite, and post-infection IBS. In our setup, we carefully look for all these. Then if the patient is having IBS-D, we treat with serotonin blocker. This includes ramosetron, ondansetron. If they don't work adequately, we often add a bile acid binding agent such as cholestyramine. If still it doesn't work, then we try rifaximin and probiotic. And mixed IBS, we have no option but to give gut microbiota modulating therapy. Thank you so much. In many of these situations, we try low Fodmap diet, but we all know for low Fodmap diet in India is difficult because Indian diet is very high in Fodmap. Thank you so much.
Thank you so much, Prof. Uday Ghoshal. It is very important, because many of our patients who come to our office is IBS. So if you can master this IBS thoroughly, you will be a very good gastroenterologist, I think. Very important. So we move to our question Q&A session. We have already so many questions here from our participants. First is from Prof. Raja. Hello, Prof. Raja.
Yes, I can hear you, Kaka.
Yes. There's a case with the uveitis patients. Uveitis patient. She came to Singapore and checked for all kind of infections. But this patient actually had a very troublesome abdominal pain and diarrhea. But when she came to Singapore, she just concerned about his red eye until the vision is getting low and low. And she didn't tell the doctor in Singapore about the gastro problem. And the gastro problem just treat her with many kind of treatment for her uveitis and even for anti-tuberculosis medication. And one day, this patient come to me, and I just get things that this is maybe part of the Crohn's disease that affect the extra intestinal problems. Then after I gave the adalimumab, the gastro problems, all diarrhea are resolved spontaneously, and even the redden on her eyes is resolved. So I want to ask you, how can we exercise this to our doctors that it could be possible that uveitis could be part of IBD, because oftenly we misdiagnose for this problem. Not only once, but sometimes we oftenly misdiagnose. Thank you.
Thank you, Dr. Kaka, for the questions. I think we have to admit that extra intestinal manifestation in Asia Pacific region among IBD patients not as common as in European or North America. And awareness among ophthalmologists, dermatologists, orthopedic surgeon, rheumatologists about IBD, in my opinion, still low. I mean, for the last 6-7 years or so, I hardly got the referral from ophthalmologists about anterior uveitis, for example, patients who keep coming. And also the ophthalmologists actually start using monoclonal antibody injection as well. So we have to be aware of that. And not only uveitis, Dr. Kaka, but also a pyoderma gangrenosum by dermatologists, peripheral arthralgia, back pain that visited orthopedic surgeon, for example, visited rheumatology with a lot of autoimmune disease.
Yes.
And I think the awareness among other clinicians about IBD is still low. I think we are in the era in which we cannot afford to give a presentation or to join the conference among our group only. We have to spread our wing. We should go to meet psychologists, even psychiatrists, and listen to their perspective. So I think collaboration and increasing knowledge, attitude, and practice toward some people still believe IBD is a Western disease in Asia. They still not believe that it's common, but actually it's wrong. So yes. I think continuous education like this will be one of the strategy, Dr. Kaka.
And the most importantly, that IBD can be concomitantly with IBS, right? So many of specialists could work together for this.
Yeah. So and I think a lot of Crohn disease, maybe Prof. Ghoshal will know, a lot of small bowel Crohn disease or IBD, IBS overlap syndrome is also problems. So we do not want to use biological agent if they got a lot of symptoms suggestive of irritable bowel syndrome.
Really?
Sometimes, yeah. So sometimes those who get a lot of IBS symptoms in the mild Crohn disease, you probably need to use a lot of magic bullet for the IBS strategy rather than using immunomodulators or
maybe you can use it all together.
Well, we have to really make sure. I mean, the criteria for use of biologic, Dr. Kaka, moderate to severe Crohn disease, moderate to severe ulcerative colitis, perianal fistulating disease, and very severe EIM. So the rest are really not much evident to you. So, and biologic is very expensive.
Yes.
So we really have to be super selective. We cannot behave like other part of the world, and the IBS is much common. Unless Professor Ghoshal would like to add on.
Yes, maybe later on, Prof. Raja, I will have another question for Prof. Ari. Prof. Ari, someone asked you about which is more frequent, intestinal TB or intestinal Crohn's disease in terms the frequency, because like your case explained before, that this patient finally get operated, and I assume that the anti-tuberculosis is not working very well because this patient died. Because in the intestinal tuberculosis, usually the absorption of medication is disturbed. So is it possible that we give intravenously anti-tuberculosis medication? Prof. Ari, I think you are still muted.
Yeah, I think we just only one medicine that we can give to our patients with intestinal tuberculosis just by infusions, maybe like quinolone or something like that. But there is for the first treatment that our pulmonary doctors don't recommend to use the quinolone in this case. And also maybe if you give streptomycin. But in my case, I think it is worth if we just give patients with intestinal tuberculosis by oral anti-tuberculosis. But the important things we must care at if, I mean, after 6 months, not improve, so we must think about maybe Crohn disease as a background of our intestinal tuberculosis. I think this is important things that to manage patients come with the first suspected intestinal tuberculosis. This is my comment about your question.
Yeah. Regarding the case, Prof. Ari, how come that patient proceed to resection? Because could it be just by anti-tuberculosis to make the lesion resolve and the obstruction release itself, or what is the indication actually?
Yeah, because at the time the surgeon see that the patients with the acute abdomen conditions because of preparation. So I mean, for the preparations, we must we must to cut the problems first, and then we can continue to the medicine because this is emergency condition.
So that's an emergency, Prof. Arya.
That's
so
right.
That's the emergency
To the preparations.
Okay, thank you, Prof. Ari. So we have a question from for Prof. Uday. As we know that from your presentation, you talk a lot about post-infectious IBS. So the question is, how long will it happen after the infection resolve? Is it in the moment like in a 1 week or in days? Because usually after diarrhea happen, the patient also got like bloating or abdominal discomfort. Is it part of post-infectious IBS? And regarding the rifaximin that you told us, unfortunately, we don't have it here. We just have norfloxacin or other quinolones. Can it replace rifaximin for the treatment of IBS? Thank you.
So both are very important questions. Let me tell you, according to Rome criteria, you diagnose IBS when somebody remains symptomatic for more than 6 months. So therefore, if a patient following an acute infectious gastroenteritis continue to have symptom after weeks, according to Rome criteria, we can't diagnose him having IBS because Rome criteria requires he to suffer for at least 6 months. So we have coined a new terminology for this patient. This is called chronic bowel dysfunction. So if after an acute infectious gastroenteritis, somebody continues to have symptom, we call these people having chronic bowel dysfunction. Let me tell you, a good proportion of those who continue to have symptom, whom we call as chronic bowel dysfunction, they evolve to post-infection IBS. That means they remain symptomatic for longer than 6 months. Now, only good part of the post-infection IBS is that post-infection IBS often remain for a shorter while, or prognosis of post-infection IBS is better than common garden variety of IBS. At least we have 3 studies on this issue. That means if somebody has post-infection IBS, he will more often resolve, his symptom will resolve, his disease will resolve in 5 years' time. Now about second issue, what you are saying is rifaximin and norfloxacin. Yes, when we did this study, that was the first study on antibiotic in relation to SIBO in patient with IBS. In India also, we did not have rifaximin. So we used to treat the patient with norfloxacin. But rifaximin is broader in spectrum. Rifaximin is not absorbed at all. The absorption of rifaximin is 0.4%. Rifaximin doesn't lead to resistance of the bacteria. This has been studied in vitro as well as in vivo, That means if you give rifaximin to somebody, he doesn't develop resistance. So therefore, I would not say that norfloxacin is the best replacement for rifaximin, but temporarily you can use norfloxacin, but in time to come, I wish your country also get rifaximin.
Yes, interestingly that as we let the patient suffer so long time until 6 months, so they can get diagnosis of IBS. Is it possible that we shorten the diagnosis of IBS maybe using colonoscopy, and if there's no sign of a lesion in the colonoscopy, we can assume that this is maybe IBS, something like that? Because I think it's...
Because problem is if you do colonoscopy and if it is normal, it only tells you that he doesn't have IBD. But because Rome wants that the disease should be chronic, then only we should call it IBS. So this 6 month remains. Though some internal discussion is going on in Rome, where I know that it may be changed in future. But I tell you, till then you write chronic bowel dysfunction as your diagnosis. You don't write IBS. You write post-infection chronic bowel dysfunction or CBD, and you can treat them as IBS.
Okay, so just it's only in terms of terminology, right?
Yeah, that's right.
Terminology. Okay, so hopefully it will change in a better way. So
Yes.
I'll go back to Prof. Raja. Regarding the diagnosis by colonoscopy, can we not looking for the pathology, because sometimes the result of histopathology is not reliable. You know, it's very difficult to get a result like Crohn's or ulcerative colitis, or even tuberculosis. Maybe it's in my experience, because we know that India, Indonesia is the first and the second country with tuberculosis. I usually, if we saw large ulcer with yellowish or bridge signs, so I must be assumed this is tuberculosis. It's just for me. Or maybe you have another specification or maybe other criteria for it, because very troublesome for diagnosing, is it tuberculosis or Crohn's disease, or maybe just colitis ulcerative. Please, Prof. Raja.
Thank you, Dr. Kaka. I think we have to look at in the various clinical case scenario. If you have the first patient coming and you saw the lesion, whatever type of ulcers, longitudinal or circumferential, I think that the TB PCR has to be done, regardless classical features of Crohn's disease. And I think we have to be extra vigilant in that. For the first time presentation, TB must be excluded unless you are very confident enough. And even when we diagnose this patient with ileocecal Crohn disease in particular, or colonic Crohn disease, or sometimes segmental ulcerative colitis, on the treatment, we also need to be vigilant about not only TB colitis, but also infectious colitis, CMV colitis, or any other form colitis. And even the scenario when this patient on the long-term treatment on the immunomodulators or biologic, still they have a risk to develop TB colitis. So, but the level of suspiciousness has to be very high in the beginning of the patient. And if the patient somehow not responding for the medication, and there is no clinical, biochemical, radiological, colonoscopy improvement. So I think I will bring routinely 3 months or sometime earlier 2 months post-empirical anti-TB treatment for TB colitis, because usually this patient will demonstrate the weight can go up very quick, the markers can go down very quickly, the patient lost night sweat, got better, and when you do colonoscopy from the first baseline, it's much, much better. But having said that, I also got cases where ileochronic disease and TB next to each other. So, you know, and the patient very sick, sometimes we have to combine the treatment. So be very careful. And now I think if you ask also your oncologist, they do use a lot of immunotherapies. The checkpoint inhibitors colitis is rising steadily, and mimicking like neoplasia, ulcerative sigmoiditis, and Crohn disease. So I think all in all, 80% of the diagnosis is based on the history taking and examination. We only rely 20% for all these sophisticated MRE and all these things, you know. But I think we really have to having the regular multidisciplinary meeting where we invite also a surgeon who doing a lot of endoscopy too. And more importantly, pathologists also in Malaysia, very small number who are dedicated their work to the IBD. Because I'm sure in your place too, the lot of terminology, non-specific colitis.
Yes, yes.
Please correlate with your clinical finding, right?
Yes, of course.
So it doesn't mean anything. It doesn't mean anything.
Yeah.
So,
Prof. Raja, interestingly that yes, I'm agree with you that sometimes we have to think about concomitantly the IBD will happen with also colitis tuberculosis. And regarding that, I usually choose 5-ASA like mesalamine because I think it's more safe in tuberculosis colon for using mesalamine, and also I also give anti-tuberculosis treatment. What do you think?
now you have to know mesalazine is really not useful for Crohn's
Yes,
disease.
I know. I mean for
affecting the last part. Yeah.
I mean,
but then again, if you use two treatment, anti-TB and mesalazine, how are you going to decide for the long-term therapy after the anti-TB is finished? And it could be you add on extra cost to the patient too, and extra cost to the government. I think we really have to do either full-blown empirical therapy for TB, which is much common, or using the steroid in the beginning. And the first few weeks is the critical. But if the patient are very sick, I think in the inpatient setting, extra precaution need to be given. Yeah.
Thank you, Prof. Raja. The next question is for Prof. Ari. Regarding the diagnosing of intestinal tuberculosis or intestinal Crohn's disease, Prof. Ari, is it possible that we use capsule endoscopy? Because sometimes the patient reluctantly to have an enteroscopy because it is a very unpleasant for the preparation with their condition already happened to them.
Yeah, I think you must know that you must be careful if you want to use the capsule endoscopy, because you know that the problems of intestinal tuberculosis, stenosis. So make sure if there is no, maybe first we can do perform the follow through first to know if there is a stenosis or not, because you know if there is a stenosis, so it is make that the capsule will stuck on this situation. But the important things, I mean, if we find the lesions from colon, I think we can try to give the empiric treatment for this patient as intestinal tuberculosis. And then if it is work, maybe the conditions will resolve, I think.
So for capsule, we have to remember about the possibility of obstruction, yeah, which is the contraindication right. For capsule endoscopy, yeah, Prof. Ari.
Yeah, that's right.
Thank you.
That's why we must be careful about that.
Okay, the last question is for Prof. Uday Ghoshal. Prof. Uday, are you still here? Prof. Uday?
I'm there.
Yes, Prof. Uday. It's very interesting about the effect of food, yeah, and even in India, it's very hard to practice the food, yeah, the food maps, because I know Indian food is very delicious, and there's a question about Nutrigenomics, because maybe we can check about what kind of food is it allowed for us, I mean for the patient with IBS. What do you think? The use of Nutrigenomics for IBS patient, because like in India, you said that it's very difficult to use these food maps. And what if you use the food Nutrigenomics in India, so the patient can choose what kind of food that can be consumed?
Yeah, I think it is an important question which requires more study, Currently, we don't have any good study, particularly in Indian perspective, but it may be in Asia in general. The reason is, but what we typically do is that those patients in whom bloating is a major problem. Now, bloating is one symptom which troubles this patient most. So what happens is there we ask the patient to choose between having the Indian delicacy on one side and having symptom at the same time, or avoiding the Indian delicacy food and reducing his or her symptoms. And I tell you, many patients actually tend to follow our advice, but we do not do it permanently. My experience is hardly 50% patients really have substantial improvement following food restriction, not more than that. Those who have real improvement on restriction, we ask them to re-challenge with one after another high FODMAP food, so that now patient identifies that which particular high FODMAP food trouble him most rather than all the high FODMAP food. That is one issue. So on the other hand, those who don't respond to reduction of FODMAP food, obviously they don't respond, therefore they discontinue. One more unique issue that comes in India, particularly the northern part of India, as high as 90% people are pure vegetarian, pure vegetarian. Now, what happens is, what we found is many of them have subclinical vitamin B12 deficiency. And vitamin B12 deficiency causes diarrhea. So in my clinical practice, I ask, is he a vegetarian? And if he's a vegetarian, we get his mean corpuscular volume tested. If MCV is high, we replace them with B12, and many patients, at least this clinical experience, we have not done any formal study, show improvement. As far as your further question is concerned, that which food to restrict, I tell you, my experience is I typically tend to restrict the milk and milk product. The milk and milk product is one thing which causes a lot of bloating. And in one study, what we found is if you diagnose lactose malabsorption using conventional 50-gram load of lactose, then you restrict them of lactose, they don't respond. But if you reduce the amount of challenge dose of lactose to 25 grams, and if that gives you positive result, they have 10 times more chance of improvement following lactose withdrawal. So I tell you, this is an area which is evolving. We need more studies. It is difficult because Indian food means there will be a lot of onion, there will be a lot of garlic. All those are actually high FODMAP.
Yeah, so still trial and error. Maybe Prof. Raja, do you have any experience using Nutrigenomics?
Well, I think the area of probiotics, prebiotics, nutrigenomic, pharmabiotics is still at the area of research, Dr. Kaka. I mean, at this moment, the recommendation overall is weak and is debatable. Yes, I do occasionally use probiotics for IBS, constipation, and those who rarely got pouchitis, mostly with the antibiotic-associated diarrhea or acute gastroenteritis. But I think a very premature and still under intense research activity, all these pharmabiotics or nutrigenomics, all these things, Dr. Kaka, I think we cannot endorse until a lot of studies, in particular randomized clinical trial in many conditions. Otherwise, we have no specific target. It's much better than placebo. Placebo probably better than all this taking thing and waste a lot of money.
Yes, because for me myself, if I got IBS, it is very hard for me to restrict myself for many delicious food. So I really hope for this Nutrigenomics, so I can check whether what kind of food is suitable for me and which is not. So I think this is a very interesting discussion we have so far, and due to the time limitation, I think we have closed this session. Thank you so much, Prof. Raja, Prof. Uday, and also our beloved Dean, Prof. Ari Fahrial. Shall we have any photo session, Prof. Ari?
Yes, please.
Mbak Indah?
Yes. Wait a sec. Okay. 1, 2, 3. Once more, 1, 2, 3. Thank you very much, everybody. Bye-bye.
Thank you so much, Prof. Uday, Prof. Raja, Prof. Ari. Thank you so
Uday.
much. Assalamualaikum. Selamat sore. Good evening.
Thank
And
you.
good morning, Prof. Uday. Good morning.
Good morning. Good morning.
Okay.
Good evening.
Have a nice day. Thank you again for the invitation. Thank you. Okay, bye-bye. Assalamualaikum.
Waalaikumsalam. Thank you.